Shall we start a paper? Fine. So, Bismillahirrahmanirrahim, and a very good morning to everybody. Today we shall be starting up with the lecture session on calcium and phosphate homeostasis. Okay, and we have to have an in-depth knowledge about the calcium and phosphate homeostasis, because it would be coming in much of the physiological sequence in most of the organ system. So having said this, calcium is the most abundant cation in the body, around 1 to 1.5 kilograms, and 99% of the calcium is present in bones and teeth in form of mineral, that is hydroxyapatite. This is a calcium and phosphate and OH group. Calcium regulation involves basically 3 tissues and 3 of the hormones. The 3 tissue system is the bones, the intestine and the kidneys, and the 3 hormones would be the parathyroid, the vitamin D and the calcitonin. Just to make it clear right here that vitamin D has been always considered into a hormone rather than a vitamin. The phosphate, the organic phosphate compounds are present in the structural unit of cell, and inorganic phosphates are also associated with calcium in the bones and teeth, because as we told, the calcium hydroxyapatite is a mineral with the calcium, the phosphate and the OH group. The total phosphorus in the adult human body is around 12 grams per kilogram, and the serum phosphate plays an important role in regulating the neutrality, and it is in the equilibrium with the bone and the cellular organic phosphate. The blood level is held constant by regulating phosphate excretion by the kidneys, and mainly 2 of the stuff do it. The hormones controlling would be taking care of both the calcium and the phosphate. Why this calcium regulation is so important? From our past knowledge, we know that it is for the structural integrity and metabolism of the bone, like the bone growth and the remodeling. Similarly, tooth formation. Hemostatic mechanism. In clotting mechanism, definitely calcium is factor number. You have clotting factors from 1, 2, 3, 4, 5, 6. Calcium is 4. Okay, calcium is clotting number 4. Most of the clotting factors are produced from clotting factors are protein produced from liver, except for calcium would be the best answer also. Calcium you do not produce in liver, huh? So if you find a 4 right there, you can go for it. Does calcium has a role in synaptic transmission? Yes. Whenever the action potential reaches the end of the presynaptic neuron, the calcium voltage gated calcium channels open, and once the voltage gated calcium channels open, there is chance of calcium getting in and causing the vesicular release of the neurotransmitter. So synaptic transmission in excitation contraction coupling. In excitation contraction coupling, for the muscles to contract, you not only need depolarization inside the muscle, but also kathir amount of calcium being released from the sarcoplasm of the muscle itself, so that it can interact with the troponin. Okay, so that troponin would have an action on tropomyosin, so that the actin and myosin can bind and bring about a muscle contraction. So in muscle contraction, definitely calcium has a role. Once the muscle contraction is there, you need a calcium, okay, and that for the muscle to relax, you want to pump back the calcium back again into the endoplasmic reticulum of the muscle. Rest of the steps where calcium might be needed is for the excitability of the nerve and muscles, for transmembrane ion transport, as a second messenger system, cell motility and gene expression, just to name a few. Whenever we happen to measure calcium, basically we do it for the serum calcium level, and it comes out to be 8.4 to 10.2 milligrams per deciliter, or 2.1 to 2.8 millimoles per liter. But as a good doctor, you should be knowing that the value that we get right there is gamma of 3 type of calcium that you have in your body, in the plasma. That is the ionized calcium, that is the protein bound calcium, and that is the calcium complexed with the anions like citrate, sulfate, phosphates. So once you talk of plasma calcium, it is gamma of all these 3. But the question arises right here is to bring about all the effect like the nerve excitability, transmission of the synaptic transmission, the release of vesicles, neurotransmitters. Which of this calcium is required? The physiologically active calcium, that is the ionized form. So if I get a plasma value of say 10, so how much calcium is really working, physiologically active? 5. A clinical scenario comes right here that you have some amount of 40% of the calcium bound to proteins. Somebody having a disease who is losing proteins, like maybe nephrotic syndrome, like maybe chronic liver cirrhosis, okay? In this you have high protein in plasma or low protein in plasma? Low protein. So you get the value same as 10, for instance, but in that case the fraction attached to protein would be more or less once you have less of protein? Less. So there would be more of ionized one, that is to be taken care. That's why in clinical condition of like hypoalbuminemia, I do not go with this measured one. If I'm knowing the NAFR is of nephrotic syndrome, I do not go with just the calcium measured. I see it in a normal range, I say okay, it's good. No, there is what you should keep in mind, that since there is low of protein, so there are chances of ionized calcium being high. So you have to get a corrected value by using this formula. The calcium corrected would be the calcium that you have measured, okay, plus multiplying 0.8 to the calculation of 4 minus whatever the albumin, plasma albumin level is there, okay. So definitely the corrected would come more or less. Corrected value of calcium would come as more or less, the active calcium. More, because you are already measuring the measured one plus something that is coming from right there, you are adding it. Okay, so keep this thing in mind. Regulation of calcium balance. As we have told, 3 of the hormones and 3 of the organ system or tissues that would be taking care of the calcium balance. Right here, calcium and phosphate right there in the center in the blood. Your GI system, your renal system and the bones do participate in calcium homeostasis. Also from the hormones that are coming from the endocrine system. So these are the 3 systems that are taking care of calcium phosphate homeostasis. The same slide, but with a particular more detail about which one, as we have talked about the 3 of the hormones, parathyroid hormone, calcitonin and vitamin D3, which of them would do what. So right here you can see the parathyroid increase the blood calcium, whereas calcitonin inhibits the bone reabsorption. The vitamin D increases the synthesis and definitely causes the absorption of the calcium from the intestine. Increased calcium absorption from the intestine, that is the role of vitamin D3. We will detail it a bit more as we move with the lecture. The regulatory mechanism comprises of the intestinal absorption is vitamin D dependent, the duodenal and the proximal jejunum. Divalent ions are absorbed from duodenum, di, 2. Renal tubular reabsorption and excretion is also there, and there is exchange of calcium between plasma and bone that causes the bone remodeling. Plasma calcium homeostasis depend upon the balance between the hypocalcemic state of effect of calcitonin and hypercalcemic effect of parathyroid hormone, vitamin D and calcium intake. So this is what you have to keep in mind, and definitely once you know which one of them is doing what in which of the organ system, you are through. Parathyroid and calcitonin, physiologically they have opposite effects. Okay, one of them is going to bring the calcium level in plasma high, one of them is going to bring the calcium level of plasma low. So right here, whenever there is decreased calcium in the blood, parathyroid is released, and parathyroid has got 3 of the important function: increases the reabsorption of calcium in the kidneys, there is release of calcium from the bones by stimulation of the osteoclast, and stimulation of vitamin D production by the kidneys. Vitamin D is produced from the kidneys. This is the 3 of the functions of parathyroid. Finally, this would bring an effect that the calcium in the blood would be restored. Whereas calcitonin, whenever there is increase in calcium in the blood, what is there is increased excretion of calcium from the kidneys, and there is deposition of calcium in the bone. Finally, this would restore the blood calcium level. So you can see right here, these are working in opposite scenarios. These are working in the opposite scenarios. Having said this, calcium absorption in small intestine, both by active and by active transport and by diffusion. And for this we need to have vitamin D in form of 125 dihydroxy vitamin D3, also called as calcitriol. This regulates the amount of cytosolic calcium binding protein and activates the active transport system for calcium. Whereas parathyroid hormone indirectly increases the small intestinal absorption by enhancing 1-alpha hydroxylase activity and calcitriol synthesis. We have just studied parathyroid increases the synthesis of vitamin D3. Okay? But something about 1-alpha hydroxylase activity. Okay, we'll come to that. Renal excretion, about 10% of the calcium that we take is excreted out in the urine, and calcium bound to plasma protein, obviously anything that is bound to plasma protein is not going to be filtered out, so you cannot lose it. Ionized and complex form are filtered in the glomerulus, okay, and they can be lost in urine. 70% of the filtered calcium is reabsorbed in the proximal tubule, 20% in the loop of Henle, and 9% in the distal tubule. Calcium is an important cation that you cannot lose it in urine. Although it is filtered out, as you can see right here, the ionized one and the complex one, but most of them is taken back. Parathyroid hormone, the one of the function is to increase the formation of vitamin D3, correct? And the other function is the calcium sensing receptors on parathyroid cells. Okay, they detect the serum calcium concentration. Whatever blood is flowing through the parathyroid, these cells would detect the level of serum calcium and accordingly and determine the set point for the serum parathyroid hormone concentration. In contrast to most secretory process, low calcium level stimulates parathyroid secretion, whereas high calcium level inhibits the parathyroid secretion. Parathyroid is secretion once the plasma calcium is low. What is the role of magnesium? Magnesium is required for parathyroid hormone release and for its effect on target tissue. And for this reason, any disorder of magnesium metabolism may manifest as hyper or hypoparathyroidism. So magnesium has a role for the secretory process of the parathyroid. That is the idea. If okay, once we move to tetany, we'll just tell me about this magnesium. I will correlate it for you. Action of parathyroid in the bones. What is the main action for what it would do for the plasma calcium? Parathyroid raise the calcium in the plasma. Okay, so what it would do to the bone?
Take the calcium.
Increase bone formation, increase bone reabsorption. Reabsorption. So which is the cell responsible for reabsorption? Osteoclast. So it's shown there. From the GI, it is the vitamin D that is important for uptake of calcium. So indirectly parathyroid enhances the formation of the vitamin D, and then the GI absorption of calcium and phosphate is there. In the kidneys what would be there? Reabsorption of calcium and excretion of phosphate. Reabsorption of calcium and excretion of phosphate. Okay, in the kidneys. And this generally happens in the distal tubules, collecting ducts, and the ascending loop of Henle. In the kidneys, the calcitriol is formed in the kidneys. That is, the one hydroxy group is added more in the kidneys. How many hydroxy group do you see in this calcitriol? 2. So one is added in the kidney. One is added where?
Liver.
In the liver. In the liver. So that's why 2 hydroxy group. Finally, you have a product called as calcitriol, very active. So parathyroid, if you happen to see, it would enhance the osteoclastic mechanism. It would enhance the GI uptake of calcium through vitamin D, and it would enhance the formation of vitamin D3, that is calcitriol. In kidneys, if you talk of direct action, there is increased reabsorption of calcium and excretion of phosphate. Having said this, this is the important diagram that you should understand for a while. Right here, this is the bone. Right here, it is the surface of the bone. On the surface of the bone, you have bone cells, the osteocytes, osteoblasts. Whenever there is a parathyroid, and what you should remember is that this osteoblast, right here for a simplified diagram, the sugar of osteoblast is bone formation, okay? But you have to remember this osteoblast also produces 2 of the things. One is called as the RANK ligand, rank ligand, and one is the protein called as osteoprotegerine protein. So what you have to see into this is osteoblast is producing both of these. In the normal scenario, rank ligand is taken care by this protein osteoprotegerine, a balance. Rank ligand is present and osteoprotegerine is present, that is taking care of it, combining, correct? Once you break this equilibrium, like right there, if there is a parathyroid hormone stimulation, what you are doing is you are producing kathir amount of rank ligand. Kathir amount of rank ligand is produced. Once Kathir amount of rank ligand is produced, there is a rank receptor right there at the precursor of osteoclastic cell. Osteoclastic cell are not active, they are sitting right there, they have the receptors. To activate them you need this rank ligand. Was the rank ligand was produced normally also? If some rank ligand was produced normally, it was taken care by this osteoprotein was combining with the rank ligand. But if there is stimulation of this osteoblast, there would be Kathir formation of rank ligand. So is there a chance of rank ligand to go and bind to the rank receptor on the osteoclast? If you have extra rank ligand, is there a chance to go and bind to the receptor on the osteoclast? And once it is done, that is the time when the osteoclast becomes active. You need to have rank ligand, rank receptor interaction to make the osteoclast active. Rank ligand is produced from osteoblast, and also osteoprotein is produced from osteoblast, so it was taken care. But if there is the equilibrium is broken down, the rank ligand is more in amount, definitely it has a chance to go and attach to the rank receptor. So generally we think of and we directly say as that the osteoblast and osteoclast about bone reabsorption, osteoblast about bone formation, but this is the exact mechanism what people would be looking for, and you should have an understanding to this at this level. Osteoblast, no issues, bone formation, but also very important thing we came to know today is about rank ligand and osteoprotein protein. There is rank receptor right there on the osteoclast precursors. To activate it, lazim you need this rank ligand. Generally whatever rank ligand is there is taken care by this osteoprotein. But if you make rank ligand Kathir like in stimulation or by the parathyroid, there are chances you don't have enough of osteoprotein to take care of it. So the rank ligand would move and bind with the rank receptors. Rank stands for receptor activator of nuclear factor kappa B, right here. Coming to vitamin D. Vitamin D, as we told, it is 125 dihydroxycholecalciferol. It is produced from the skin by the irradiation of the ultraviolet rays. Then this cholecalciferol is converted, one hydroxy group is included in the liver, the second hydroxy group is included in the kidneys, in the proximal tubule, and this would require parathyroid hormone for doing so. So right here, whenever the sunlight is there, we produce from the skin 7-dehydroxycholesterol. Finally, it converts to cholecalciferol, just cholecalciferol, no hydroxy group. Then there is an enzyme in the liver called as vitamin D25 hydroxylase. This would cause addition of one hydroxy group to this cholecalciferol, so it becomes 25 hydroxy cholecalciferol. But then this reaches from the kidney, and then kidney there is one alpha hydroxylase enzyme. This is the enzyme that we were talking of. This is stimulated under the effect of either there is low phosphate or there is increased amount of parathyroid. This would convert, add up one more hydroxy group, so it becomes 125 dihydroxy cholecalciferol, and this is called as calcitriol or active vitamin D. So this is the vitamin D that would be having its physiological action. The same 1-alpha hydroxylase activity is in the kidneys, and it converts 25 hydroxy vitamin to 125 dihydroxy vitamin D3. Not much into this. What is the function of vitamin D3? Definitely it helps in intestinal absorption of calcium, but how? Increase intestinal absorption of calcium and phosphate absorption. What it does is it makes on the luminal membrane it makes the calcium channel and calcium binding protein called as calbinding in the cytosol. So there is induction of calcium channel on the membrane, and once the calcium gets in, the calcium binds to a cytosolic protein called as calbindin. So both of them take care of the calcium. Also there is increased calcium and phosphate reabsorption from the kidneys, and by inducing active calcium reabsorption in distal convoluted tubule. It is the distal convoluted tubule where calcium and phosphate are reabsorbed under the effect of vitamin D3. Also there is increased calcium transporters through cellular membrane in the bone, that is the increase in the bone reabsorption. So not much into this. This would be of help. How we make vitamin D3 from the skin, how it matures in the liver and kidneys, and what is the effect. What is the effect on gut? Absorption of calcium and phosphate. What is the effect on from the bones? Calcium and phosphate. And from the kidneys, again, calcium and phosphate are reabsorbed, taken into the blood. Calcitonin. Calcitonin is coming from parafollicular or C cells in the follicles of the thyroid gland. Calcitonin comes from, parathyroid comes from which gland? Parathyroid. And calcitonin comes from? Calcitonin comes from? Yes, that is a catch right here. If you happen to see right here, calcitonin comes from parafollicular cells of which gland? Thyroid. Calcitonin is not coming from parathyroid, mark it. Calcitonin is not coming from the parathyroid. Okay, that is a catch right here. Another thing about is that definitely the calcitonin has got opposite effects of parathyroid, so there would be decrease in absorptive activities, there would be deposition of calcium, there would be inhibition of calcium reabsorption from the kidneys, and there would be inhibition of the phosphate reabsorption. Effect of calcitonin is much more greater in children because the bone remodeling occurs rapidly in children by bone reabsorption and deposition. So calcitonin is basically having reverse or opposite effects of parathyroid. This would be helpful, this diagram. How many organ systems are taking care for calcium and phosphate metabolism? The GI system, the kidneys, the bones. Okay? How many hormones are taking care of this balance? 3. The parathyroid, the calcitonin, the vitamin D3. 3 of them. Okay? Right here, this is the GI system, this is the blood. What is the effect of vitamin D3 on the calcium and phosphate? Reabsorption. Does any direct effect of parathyroid or calcitonin right here on GI? On GI, direct effect of parathyroid or calcitonin? No direct absorb, no direct action. Indirectly it enhances the formation of vitamin D. True. But no direct action. That's why we have just shown only one arrow right there. Right here in the kidneys. Which of the hormones have got direct action? The parathyroid and the vitamin D3. Parathyroid and the vitamin D3 calcitriol. Parathyroid has got calcium would be reabsorbed, and phosphate is reabsorbed or excreted. Parathyroid excreted. Parathyroid has got calcium would be reabsorbed and phosphate would be excreted, whereas vitamin D3 would reabsorb both. This is the difference between the PTH and vitamin D, direct action on kidney or the renal system. Important, mark it. Okay? Coming to the bones. Coming to the bones, what would be the effect of the parathyroid and the vitamin D3? Bones. Will they? Calcitonin would? If you happen to see parathyroid mainly cause bone reabsorption. Okay? Calcitonin would inhibit it. If you happen to see right here the net effects, parathyroid increase the calcium and decrease the phosphate in the plasma. Okay? Calcitriol or vitamin D increase the calcium and increase the phosphate in the blood. Calcitonin would decrease the calcium and no. Right here, this, if you understand this, this would summarize it all. Parathyroid increase the calcium in the plasma, decrease the phosphate in the plasma. Okay? Vitamin D3 increase the calcium and increase the phosphate. What about calcitonin? If I add up right here calcitonin, what would be the effect of calcitonin? Anybody? Decrease the serum calcium, down arrow for serum calcium, and it has got a minimal effect. If we happen to move back to our slide right here, inhibits the phosphate reabsorption, inhibits the renal tubular reabsorption of calcium. So both would go down. Okay, both would go down, but not to a much greater extent. True. So this is the idea about the three organ systems and the role played by it. Clinical significance, we land up for calcium either high calcium or low calcium. High calcium called as hypercalcemia due to many odd reasons right here, maybe increased GI absorption by vitamin D excess, elevated PTH, or increased loss of bone. Bone is being lost, so the plasma calcium is high, maybe due to hyperparathyroidism, a disease, or increased bone turnover like Paget's disease and hyperthyroidism. Decrease in bone mineralization again due to elevated PTH, or decreased urinary excretion by using drug like thiazide, or there is elevated PTH and elevated calcitriol. All this would land up in high calcium level. So not for the cause, but definitely for the presentation. High calcium presents as maybe some stone, or maybe a renal stone, or as problem with the bone. Once there is maybe a PTH is high, more of the calcium is being absorbed from the bone. So like in cases of osteoarthritis, fibrosa, or arthritis. Abdominal groans, there are chances of person having constipation, nausea, vomiting, or maybe pancreatitis even. And psychic moans is about the person would be feeling lethargy, depression, maybe some memory loss, confusion, stupor, and ending up in coma. So generally we ask as a mnemonic like stone, bones, groans, and moans. All these, if present in a clinical scenario, indicate to a hypercalcemia, probably. Okay.
How about you should remind you about the magnesium concentration?
Hypercalcemia, we'll talk in hypo, inshallah. Causes of hypocalcemia would be again if you have low PTH, or PTH has got a resistance, or maybe loop diuretics, low level of vitamin D, or hypoparathyroidism, or poor intake of vitamin D. These are few of the causes for hypo. Hypo is more dramatic because generally it would present with few of the things, that is, goes with a mnemonic cascades. The person can have convulsion, problem to manage, acute emergency. Person can have arrhythmia, so it is also an acute emergency. Tetany and stridor, this is the one that is going to kill. This is the last one that is going to kill. Although arrhythmia and convulsions is also of importance, arrhythmias can also kill. But this is the problem that one has to be careful of. Yes, in adults, and mainly these signs and symptoms are mainly in adults. Presentation is bit varied in the children, but generally it follows the same pattern. If you happen to see there is increase in neuromuscular excitability because of low calcium. Calcium has got a membrane stabilizing property. Okay? So if there is low calcium, the membrane is hyperexcitable. Paresthesia, hyperreflexia, all these would be mawjood if it is low calcium. Cardiac effect would be arrhythmias. Tetany, hypocalcemia and tetany are used as the same. Tetany manifests as carpopedal spasm, or latent it would be with Trousseau sign or chopstick sign. These are the two signs related to hypocalcemia or tetany, whenever it is.
What's the connection with magnesium?
Coming to magnesium, if somebody is having a tetany, okay, Baden tetany, there is laryngeal stridor. Laryngeal stridor is because approximation of the vocal cords going into the tetanizing effect. Okay? So if approximation, the person who would be breathing in would be producing a grunting sound that is fearful and fearsome because he's going into a upper airway obstruction. Okay? Ophthalmologic finding can be papilledema and cataract later on, but these are the few of the signs. Definitely convulsion, arrhythmia and tetany and stridor. These are the one that have to be looked for and definitely taken care for. Right here. On a way to college, you find a nervous student surrounded by his friends. Knowing that you are a medical student, they ask you for help. What is the help? The student is hyperventilating, the other student, and complaining of numbness and tingling of hand and feet. And he is feeling a bit lightheadedness and dizzy, and headache and maybe some amount of chest discomfort or chest pain. While his friends call you, that they find you that, okay, you seem like a doctor, by the time you reach right there, suddenly his hands and feet become stiff. His hands and feet have become stiff, and he is lying down. Maybe the students made him lie down, so his muscles have gone in tetany. His muscles have gone in something this way. You find him this way. Corpopedal spasm, this way. This is nothing but hyperventilation can cause tetany. Whenever a person hyperventilates, he breathes out most of the carbon dioxide. If most of the carbon dioxide is going out, the plasma is becoming acidic or alkalotic. Carbon dioxide going out. Carbon dioxide is an acid gas. You are throwing away all the acid out. So yourself becomes alkaline. So respiratory alkalosis causes increased binding of calcium to albumin. Increased binding of calcium to albumin. Respiratory alkalosis. And thus would lead to free calcium would increase or decrease? Free calcium. Decrease. The free calcium would decrease because most of the calcium has bind to albumin. The net body level of calcium would be changing or same? Same. The gross level is same, 10. Okay? But due to change in the ionized part of calcium, there are presentation. That's why physiologically active form is the ionized form. So this is what you happen to see. What would be the treatment? He's running low on calcium. So what should be the treatment? Just ask him he should breathe easy if he's aware of, as like he has been brought in coma or so, and you are in ER. So what is the treatment for hypo? He's running low on calcium. What is the treatment? Give the calcium. He's running low on calcium, give the calcium. That is the treatment. By then giving the calcium and by then making the correction, is still his tetany is not improving. His tetany is not improving. Then you have to think that this tetany might be due to the magnesium, because magnesium was having an effect on calcium release. Okay? Magnesium, if we talk, initially we talked about the magnesium in the very initial slides. Okay? Magnesium was important for the release of the calcium. If you happen to look right there, magnesium. Role of magnesium. Magnesium is required for parathyroid release and for its effect on target tissue. So how do you bring the body level calcium high? By stimulating the parathyroid, okay, or by directly giving the calcium, that is for sure. For this reason, if there is disorder of magnesium metabolism, that may manifest as hyper or hypoparathyroidism. So if the tetany is not correcting even after giving the calcium, then definitely you have to stimulate the parathyroid hormone. Okay? So that parathyroid hormone release is guarded by magnesium. So just you have to add the magnesium to the therapy and the condition would improve. That is the idea. So hyperventilation can cause tetany or hypocalcemia. Everybody got it right? Hypocalcemia, because calcium binding to albumin. Correct? Finally saying this, these are just this is the convulsion or the spasm that the person would be having. He would be having more of reflexes. Laryngeal spasm would be there. You see the approximation of glottis closing. Okay, so there would be stridor. There can be arrhythmias, there can be optic disc that can be choked up. Okay, there are two signs called as Strozio signs and chopstick sign. Strozio sign, in the chopstick sign, what you do is you just tap the distribution of facial nerve right here near the parotids. So there would be a contraction of that side. That is saying that this snuffer is running low on calcium and there are chances of landing into a tetany. The other way is inflate the blood pressure cuff up to a certain level, up to its systolic level, hold it for a while. Once you hold the blood pressure cuff for maybe a minute or two, the hand goes into the spasm. The hand goes into the spasm. This is also just to check up for, is there a possibility of having this person is running low on the ionized calcium. That is how it sees. For vitamin D deficiency, we do not go into detail. The rickets and the osteomalacia. The rickets is in the children and osteomalacia is in the adults. Osteoporosis, a porous bone, vitamin D also plays a role along with calcium for the formation of osteoporosis. If we happen to see if this is a child having rickets, you can see the bowed leg. This is the typical bowing of legs for vitamin D deficiency. This is a diagram or a chart just for you to understand the difference between osteoporosis and osteomalacia. Can you tell me the basic difference in osteoporosis and osteomalacia? Osteomalacia is Mafi mineralization, Jadid mineralization, correct? Osteoporosis is destroying the Gadim mineralization. My bones were mineralized, but it is being now taken away. First thing. Second thing, what you see is, there is, in osteoporosis, there is a definite bone loss. Osteoporosis, there is a definite bone loss. Because you do not only take away the mineral, the bone would become a bit thinner. That is the normal bone. This is the osteoporous bone. This is the osteomalacia. In osteomalacia, the bone is going to be the same. Okay, just that it is mafi mineralized, that's it. But in osteoporosis you have a bone loss. In osteoporosis you have a bone loss. So there would be symptoms and the treatment. We are not going into those details. Inshallah, that would be covered up by people. So but the idea about understanding the difference between osteoporosis and osteomalacia is important. So with this we end up right here. Inshallah, just go and read it. If any doubt, we shall